Welcome to Roadmap to Residency, Evidence-Based Applications. In this video, we will be talking about medically relevant parasites. So, first of all, we have Entamoeba histolytica. The disease is called as amoebiasis, which causes dysentery. There can be lesions called as inverted flag-shaped lesions in large intestine with extension to peritoneum and liver, lungs, brain, and heart. Blood and pus in the stools can be seen, and it can also cause liver abscesses. It transmisses through cyst. Fecal oral transmission is there through water, fresh fruits, and vegetables. Diagnosis is via trophozoites or cyst in the stool and serology. The treatment is metronidazole followed by paromomycin. Giardia lamblia causes giardiasis. It has a ventral sucking disc which attaches to the lining of the duodenal wall, causing a fatty, foul-smelling diarrhea. Diarrhea is due to the malabsorption in the duodenum and jejunum. Now, there can be cyst, there can be transmission through cyst, and there can be fecal oral transmission. In diagnosis, we can see pure-shaped trophozoites with bilobed nuclei or cyst in the stool, or fecal antigen testing can be done. The treatment is also metronidazole. Cryptosporidium species causes cryptosporidiasis, which causes transient diarrhea in healthy hosts or severely immunocompromised host. It can be transmitted through cyst and undercooked meat. There can be acid-fast cyst in the stool, which can be used for the diagnosis. Nothing is 100% effective in the treatment of Cryptosporidium species, whereas nitroxoxanide, paromomycin, or azithromycin can be used. Cytospora belli causes transient diarrhea in AIDS patient, and diarrhea mimics Giardiasis malabsorption syndrome. It can be transmitted via cyst, by injection, by fecal oral route. The diagnosis is via the acid fasting, where we can see elliptical cyst in the stool. The treatment is TMP-SMX. Cyclospora chiatenansis causes self-limited diarrhea in immunocompromised host and also severe diarrhea in AIDS patient. We can see acid-fast spherical cyst in the fecal matter, and the treatment is TMP-SMX. Microsporidia causes microsporidiasis. It causes debilitating diarrhea in AIDS patient, and it is transmitted through the ingestion of spores. We can see gram-positive acid-fast spores in the stool. Trichomonas vaginalis causes trichomoniasis, which is often asymptomatic or for the vaginal discharge can be there. It is transmitted through sexual transmission, and we can see motile trophozoites in the methylene blue weight mount, which is called as corkscrew motility, and the treatment is metronidazole. Naegleria flori, this causes primary amoebic meningoencephalitis and severe prefrontal headache. The transmission is via the free-living amoeba picked up while swimming or diving in very warm fresh water. It causes the diagnosis is by the motile trophozoites in the CSF, and the treatment is amphotericin B. Entamoeba causes keratitis and granulomatous amoebic encephalitis in immunocompromised patients. There can be free-living amoeba in contaminated contact and lens solution, and we can see star-shaped cyst on biopsy, and it is rarely seen in CSF culture. It can cause keratitis, and for the keratitis we use topical miconazole and propamidine. So which of the following parasites demonstrates falling leaf motility on microscopy? Yes, the answer is Giardia lamblia. Now let's talk about Plasmodium species. The typical life cycle of Plasmodium is very, very important. So here we can see the sporozoites migrate into the bloodstream, which is called as the exoerythrocytic cycle. Now, this is the exoerythrocytic cycle. This is the cycle in the humans. Okay. Now, in the exoerythrocytic cycle, then the sporozoites migrate into the bloodstream. The sporozoites invade the parenchymal cells of the liver, and then there is division of the tissue. There is division to form primary tissue schizoid in the parenchymal cells of the liver. Then this schizoid ruptures and it releases trophozoite. Now these trophozoites undergo erythrocytic phase in the RBCs and then release gametocytes. And these gametocytes are then ingested by the mosquitoes because the blood temperature of human it's so high that the gametocytic cycle cannot occur in human. So the gametocytes go on into the bloodstream of the mosquito, and then it can go on to form a maturation, division, fertilization, and form a zygote, which penetrates the stomach wall and divides. And then it can form in the stomach lumen. And then while uh, uh, the migration, it just ruptures the stomach lumen via the ruptured oocyst, and then it migrates to the salivary gland. And in the salivary gland, it is present in the mosquito, and then the mosquito transfers these all to the humans. and then the erythrocytic cycle starts in the humans. So up to this is in the humans, this is in the mosquito. Now let's talk about some other parasites. The first one we have to talk about is Trypanosoma cruzi. So it causes acute and chronic condition. Acute condition is Chagas disease, which is very, very important. And we can treat this by benzimidazole or nifurtimox. Now, another important organism is Leishmania donovani, which causes visceral leishmaniasis and is transmitted by the sandfly bite. And the treatment is istugogluconate sodium. Now let's talk about the roundworms, which are transmitted by eggs. So the important roundworms, we will only talk about that. So the first one is Interbius formicularis, which is most frequent helminth parasite in the United States. It is also called as pinworm, found in the large intestine, and there is nocturnal perianal itching. It is diagnosed by the cellophane tape, which is present in the perianal area at night time and treated by parental pamoate and albendazole. But we have to treat the entire family. The another important organism is Ascaris lambricoides, which is called Giardiasis, and it is transmitted by the ingestion of the eggs. There is bi-resistant knobby eggs. The treatment is supportive therapy during pneumonitis and surgery for ectopic migrations causing albendazole. Now, schistosoma infection is very, very important and very commonly asked in the examination. Now, schistosoma mansoni causes intestinal schistosomiasis. It is transmitted via the skin penetration. The skin penetration which causes itching, maturity in the veins of mesentery. X cause granulomas in the liver, and the treatment is praziquantel. Schistosoma hemorrhagium causes visceral schistosomiasis, and the treatment is again the same, praziquantel. So here we have the question with us. 45-year-old, previously healthy woman comes to the emergency department due to 2 days history of fever, chills, malaise, and fatigue. The patient returned from a wildlife safari in Africa 3 weeks ago. She took mefloquine for malaria prophylaxis during the trip. She was advised to continue the medication for 4 weeks after return, but stopped taking it upon arrival in the United States. Peripheral body smear shows Plasmodium falciparum. Inactivity of the medication against which of the following best explains the patient's symptoms: chloroquine-resistant strain, circulating gametocytes, dormant liver hypnozoites, exoerythrocytic lysosomes, or intraerythrocytic trophozoites. So travelers to malaria endemic areas should be counseled on mosquito avoidance measures and given chemoprophylaxis. Mosquito avoidance strategies include staying indoors at dawn and dusk, wearing insect repellent, and limiting exposed skin. Chemoprophylaxis targets the predominant species of the region and takes into account the presence of drug resistance. In Africa, where chloroquine-resistant Plasmodium falciparum is endemic, common chemoprophylaxis regimens include atovaquone and proguanil. Mefloquine is a seisontocyte that actively destroys the replicating parasites within the red blood cells. However, it is inactivated in the liver and has no efficacy against hepatic seasons. Now, because Plasmodium falciparum seasons mature in the liver over 8 to 30 days, travelers must take mefloquine chemoprophylaxis for 4 weeks upon returning from malaria endemic areas to ensure that seasons released from the liver are destroyed when they infect red blood cell. Individuals who do not take mefloquine upon return can develop intra-erythrocytic infection, leading to symptomatic malaria, like in our patient. Thank you for watching. Keep studying.